Hello, everyone. I would like to welcome you here on behalf of the Feast Center for Indigenous STBBI Research to the recording of our conversation, Revisiting Know Your Status. My name is William Gooding. I'm a mixed race person with Quechua, Spanish, and Irish ancestry. I've lived with HIV for 16 years. I've worked and volunteered in sexual health field in HIV for over 20 years, and my pronouns are he and they. I have the privilege of being the national director for the Feast Center. I'm calling today from the territory where McMaster University is located, the Dish with One Spoon Wampum Agreement territory, and the traditional territories of the Mississauga and Haudenosaunee nations. That being said, we're excited that the reach of this series is from sea to sea to sea here on Turtle Island, as the Feast Center is a national research center. I'm here today to welcome you to today's timely and important conversation in which we revisit the Know Your Status model. We will be discussing the history of the model and its effectiveness in responding to HIV in Saskatchewan First Nations communities and more broadly in the prairies. In order to ground this conversation in lived reality, we will be sharing personal stories about living with HIV as an Indigenous person, the fight against HIV stigma in community, and access to care that is grounded in culture. In doing so, we will highlight the importance of culture in the work that we do and explore systemic challenges to effective change. As always, please put any questions you may have in the chat box. Panelists will have a chance to respond to questions at the end of the conversation. In the context of the conversation series at the Feast Center, we value your participation and support for events such as this, and we welcome you to follow us on our social medias, such as Facebook and Instagram. The Feast Center has a host of resources that are open to the public, and you can find us online at www.feastcenter.mcmaster.ca. Our conversations are available both on the Feast Center website and by searching for the Feast Center's through the Feast Center's YouTube channel. Elder Albert McLeod will be leading this conversation and will be opening it for us. I'm just going to introduce Albert, and then we'll move into the talk. Honorary Doctor of Law Albert McLeod is a long-standing activist in the Indigenous response to HIV/AIDS and Two-Spirit Indigenous LGBTQI education, outreach, and advocacy. He's a First Nations Cree living in Winnipeg, Treaty 1 territory, and the homeland of the Red River Métis Nation. Albert specializes in education about Two-Spirit history and reemergence, Canada's truth and reconciliation process, and the outcomes of the national inquiry into murdered and missing Indigenous women and girls. You can find him online at www.twospiritconsultants.ca. Albert, would you be able to open for us now?
Yeah, thank you, Will, and also the panelists and participants in this online event. And in the traditions of Indigenous people, when we come together to do this work on behalf of our community, we are told by our knowledge keepers and elders and medicine people that we call in the spiritual world to guide us because as humans, we don't know everything about creation. We don't know everything about the universe, and we don't know everything about being human. So we rely on those more ancient powers, entities to guide us in the work, ones that have been around for eons or millennia or millions of years. So we open those doorways, those portals to that dimension, awaken those spirits and call them in to see us, to hear us, to guide us and help us if they can. And principally, they are the winds that bring change to our northern hemisphere as we are transitioning to spring from winter now in March. That's a significant time when we come out of the darkness, the coldness, and that really is a metaphor when we are faced mental, emotional, spiritual, psychological, and physical challenges, as we do in dealing with HIV/AIDS or the stigma related to that in doing our work in our communities. And so we open those four doorways, the east, the south, the west, and the north. And we thank the earth below for the water, the good water we have, the plants and animals that we rely on to survive, the sky world above, our connection to the universe, the planet, the moon, the sun, and the stars. to connect us to creation itself and the great mystery of the universe. And then finally, we call in the humans, the last creation, and honor each of the humans and their lived journey right now in the universe on this planet. And there's 9 billion people on this planet. That's a lot of people. Over 200 nations. And they all have worldviews, identities, cultures. And they all have responded to the HIV pandemic in different ways and have experienced it differently as well. We know today there are 4 million people in the world who do not have access to antiretrovirals. People in other nations do. So that is a point to understand that as humans, we have good intentions, but there are actually barriers around HIV and AIDS globally. So welcome, everybody. Are you going to introduce the panel, Will?
Okay, no, for sure. So I could, yeah, let me do that. So I'm going to be introducing the panel in order in which people will be speaking. Dr. Ibrahim Khan is a public health physician and works as a regional medical officer in the First Nations Inuit Health Branch, Saskatchewan region, Indigenous Services Canada. Dr. Khan has worked with several health-related positions internationally, and the most rewarding work to date has been with Indigenous people in Canada. Dr. Khan says, I am an immigrant to Treaty 4 territory. I am truly honored to be working with Saskatchewan Indigenous people in health and very fortunate to be part of exciting health transformation and health service delivery at community, tribal council, and regional level. And I'll introduce Darren as well, since I know both Darren and Ibrahim are going to be sort of speaking in the same segment. So Darren Skibinski is a seasoned registered nurse with 15 years of experience working in acute teaching and community settings. He's a graduate of First Nations University of Canada and hails from Treaty 5, his home community being Red Earth Cree Nation, Saskatchewan. Darren's passion for over the last decade has been working with Indigenous communities in the realm of harm reduction, communicable diseases, HIV, and hepatitis C case management. So thank you both for being here. Albert?
So the first comments or questions or conversation is going to be about the Know Your Status, which is principally about HIV testing back in the day of 2011 and how it was introduced in Saskatchewan at Big River First Nations. And I think Atukakap was also involved in that process. So, and we know now with the recent report on the Public Health Agency of Canada from 2022, that Saskatchewan has 4 times the national rate of HIV transmission than mainstream Canadians, and Manitoba is not far behind at about 14 per 100,000 compared to 4.7%, 4.7 per 100,000 generally in Canada. So, Dr. Ibrahim, can you talk about the origins of the Know Your Status initiative and the campaign and what it's looked like over the preceding years?
Thank you so much. Hope you can hear me, Albert. Okay, yeah. Good. So good afternoon to all the panelists and good afternoon to my dear Albert and Will for inviting and for hosting this particular event. And good afternoon to everybody who is listening and joining us in this webinar. I'm really happy that I have Darren with me to speak a little bit about the Saskatchewan situation. I'm joining from Treaty 4, and I'm very happy to be part of this conversation because there is so much to learn when it comes to the Know Your Status program in Saskatchewan. And I'll just give you the highlights, what I remember from my involvement since the beginning, since 2009 and 10, and then certainly will be available for questions. So thank you so much for this opportunity. The journey, the inception, and the evolution of Know Your Status program in Big River First Nation is very unprecedented, and there is everything for everybody to hear and to inspire and to see how it has worked. The journey of Know Your Status program in Big River First Nations was not easy, was not smooth at all in the beginning. It was a lot of sacrifices, a lot of devotion, commitment expressed, shown, demonstrated by the chief and council, the leadership at that time, until today. And I'm really happy that Darren is with us, so he can certainly speak to the current status of the program. But what I recall from the memory, the way it started, was that there was quite, back in 2009 and 10, historically in Saskatchewan, not just in that time, historically, the level of racism and discrimination when it comes to HIV and when it's come to Indigenous people has been very, very, unfortunately, very high, and particularly in the healthcare system, particularly in the rural areas when it comes to Indigenous people seeking care and following the path of their journey in healing and different things. So the time it was this inception, this discussion started, the community was the time that there was an unprecedented rates of STIs in that area, and also HIV cases. And another thing that was driving the entire epidemic of STBBIs was the intravenous drug practices in that area. Poverty and access to care were extremely cumbersome. And for a lot of people, it's still very cumbersome, but for a majority of unreserved population, they have made significant strides in the past 15, 20 years to overcome some of these barriers and stigmas and racism. And I'm going to touch on some of them, but just going back to the leadership, that if leadership wasn't supporting it and behind it, beside it, in front of it, everywhere, this program would have not stood, this program would have not happened, this program would have not achieved the level of success that we currently see. So I think, to me, the most important thing for the robustness, for the viability, for the feasibility, and for the outcome it has achieved was it has a very strong leadership, chief and council, and Chief Bruce Morin was the chief at that time. And I have to acknowledge some of the really legendary people. They're still there, but some have moved on to other positions. So Chief Bruce Morin, Derek, and Leslie Ann. Leslie Ann was the nurse manager at that time. Very legendary, exemplary people that brought a huge level of commitment to this program and actually made it so desirable and so inspiring to others and for the people in the Big River First Nations. So that was the first thing. And particularly the high rates of STIs, high rates of STBBIs, poverty and intergenerational trauma, mental addiction crisis were driving many, many crises at that time. So it was just not that. It was so many other things that was driving these high rates of HIV and hepatitis C and others. Know Your Status program is purely community design, community driven, and it's chief and council endorsed, heavily endorsed, and it's a nurse-led program. The whole center of this program is a nurse, and then the nurse has connection to a lot of things, and which I will explain in a minute. The slogan of the KYS, Know Your Status program, came actually after a long internal discussion in the community with the youth and chief and council. And it was actually the youth who actually came up with this logo and the slogan, Know Your Status. And the slogan was actually, and the logo was actually designed by the youth in the Big River First Nation. So I think from the slogan to the logo, to the entire inception and the elements of the program came from the community. And that is what is really the core, the key ingredient of success. And of course, leadership was, you would have seen many leaderships in many different jurisdictions, but this leadership didn't want to let HIV go under the rug. They publicly said, we're going to deal with it. We're going to address it. We're not going to slip it like that. We're going to help our people. So that was like the key spirit behind the Know Your Status at that time. And then the program stood up, and the program core component, after a long discussion internally, was that Of course, the first thing when it comes to HIV, because of stigma and racism and many of the things, was access to testing. And testing was very, very hard and cumbersome and complicated at that time. So I think the most important piece that they picked was like, we want to have universal testing, we want to normalize testing, and we want to have testing available to everybody, everywhere, wherever they can. So I think that was the first core component that they picked. Then there was, of course, nurse is the key central part of this program. So everything is nurse-led. So nurse, actually, we had to support the nurse to make the testing happen at the community level. Endorsing the nurses, particularly from the medical health officer standpoint, Dr. Skinner was a key ally and a very strong man and an expert and a professional that I really would like to acknowledge, that actually led the success of this Know Your Status model of care. So he was involved, and I think he brought the first on-reserve clinic to a community on reserve. And it was like not heard before, not seen before, at least in Saskatchewan, that an ID clinic is happening on reserve. You don't let people travel for hours and transportation issues. They brought the care directly to the community at the doorstep. So I think the nurse-led model, the ID doctor on site, the nurse-led, the harm reduction program, referral to mental addiction, everything was thought to be under one roof. That once you walk into the clinic, you are tested, you are assessed, there are, of course, pre and post counseling, and all those elements were part of the program. And then not only HIV, diagnosis was not just the only thing they wanted to achieve. Diagnosis is perhaps easy, but then following the patient throughout that journey from diagnosis to treatment and then achieving the outcome. And I think another really strong element of success in this program was that support, the family support. And you provide that care to the patient where the patient is. So sometimes the nurses would test and counsel people in the back of the truck, in their doorstep, on the street, wherever the people were. So that made the care of HIV so convenient and so accessible and so stigma-free. And of course, all the care was provided by Indigenous healthcare providers. So land-based healing practices, intergenerational trauma, cultural sensitivity, and how do you provide a trauma-informed care to the most vulnerable people in the community? That was like the key successes of those programs that attracted one client, and then one client went and told others. So a lot of evolution happened in that time in terms of removing barriers, providing that culturally grounded care to people. People started comfortable with the care. They started opening up with the nurses and the doctors, and then they knew the pathway how to bring others to the care. So certainly that helped a lot. And the concept of Know Your Status program, the successes were very visible. People started seeing life back. People started seeing being productive. Some came for a job after their viral load was suppressed and they were on treatment and they had a good mental health status. They wanted to come to work. They actually collected their family back. They got their children back. A lot of those things happened that actually made people realize, oh my God, this program is a magic and it's amazing. And that's how this program got stronger and stronger and evolved to the current state that we see that the concept of Know Your Status program, that everything under one roof, test for one, test for all. And if you test for HIV, then we will test you for others, and linking to other programs and primary care services, harm reduction support was so robust, so amazing that people start coming in themselves, but they brought their loved ones, their families, and others. And that's how this program got its effectiveness across the minds of people. So that was one thing. With the time, the practice of having ID clinic on reserve got very, very consistent. So Dr. Skinner would be hosting monthly clinics. The nurses would do all the blood work, the follow-up, patients are ready. Dr. Skinner would come and prescribe treatment, link them to other cares and services. So the wellness wheel now is the program that Dr. Skinner and his team leads. I have many connections to other communities, but including Big River, that program, that connectivity with the ID doctor, myself, and other program services got very, very strong with time and evolved actually. Then seeing the successes of the Know Your Status, people started, program managers, directors in Big River First Nations and in the surrounding area started actually implementing those programs in their own territories with their own spin, in their own way, and actually started seeing success. And then there was a time, and it didn't happen very quickly, it was 5 to 10 years, that there was a time that we not only achieved the United Nations goal for HIV, the 1990, but also we had all pregnant women tested. No babies with HIV was born in the community because everybody was on treatment. And there was a time before pandemic, and I'm sorry, pandemic derailed many things in many areas. There was a time before pandemic that anybody who is diagnosed with HIV on any given day is linked to treatment within a week to a month. That was like the quickest time turnaround we have ever seen anywhere in a remote community or in indigenous communities. So that was something remarkable. And that was one of the essential ingredients that actually led to the achieving of the United Nations goal of 1990. So all these successes actually brought a lot of spotlight on Big River. So not only is media was behind and after the Big River community, and the chief was interviewed, I was interviewed, nurses were interviewed, patients were interviewed. So the word on the success of Know Your Status program got out from the neighboring communities to central communities. Northern communities started implementing this program. So currently we have, from one in 2010 to now, we have more than 42 communities that actually have these core elements of the program, like nurse-led service, testing, access to harm reduction program, primary care, and also having an ID clinic on site. The successes of the Know Your Status program now is translating into chronic diseases and Hep C elimination and many other programs. So that was a very positive thing that happened, that people could see life back, and the same model was applied to many other sort of crises and programs and services in the community. So with the spotlight, of course, we started, I mean, Big River is the most visited community internationally and nationally. From Ontario to Manitoba to Alberta, people started coming because the success and the remarkable achievement of the United Nations goal actually made headlines. So from United States, people started coming in, and the successes were showcased till we reached, again, with the team of Big River, we went to Amsterdam, the World AIDS Conference, and there was a Canadian pavilion dedicated to the Know Your Status program. And I think that was a very historical moment for the, to be proud as a Big River First Nations person, that more than 30 countries actually came to the pavilion, and there was a documentary made on Know Your Status program that was premiered at the Canadian Pavilion at the World AIDS Conference in Amsterdam. We had the minister with us. We had the Public Health Agency of Canada President, Dr. Skinner, myself, the Big River Health Directors, and nurses. And that was the spotlight we never thought we're going to get, or the Big River community is going to get. Then the premier meeting actually was hosted in Saskatchewan, which actually, again, Know Your Status was, again, a spotlight. The U=U, PrEP, many other milestones. There was a time that we had 0 babies born with HIV because we had initially a very large pool of HIV positive people in the community. So currently, I'm very proud to be involved with the people and with the program of Big River First Nations, and many people still come and visit the program to see the success. But again, pandemic was quite 3 years of a tough time. But again, the program the investment made in Big River through efforts, through program, through outcomes are extremely visible and palpable in the health of people in Big River First Nations, and still evolving to date. And lots of constant monitoring, quality improvement in the program that still is quite a routine practice. So that's all what I can say at this moment, and certainly there will be more to say, and Darren can share his perspective as well.
Thank you, Dr. Khan. Yeah, so we'd like to go to Darren sort of at the community level and share your insights. I know your camera's not working, so we're going to put a cat there in the picture for you. So yeah, did you want to talk about, I guess, where things are at now? I know that the HIV self-test is available in Canada, as well as the dried blood spot test, which includes HIV and syphilis. So just an overview of how are things going now.
Great, thank you. First, I want to start off with how beautiful and powerful that opening was, Elder McLeod. I appreciate that. Thank you so much for opening us up in a good way. I'm joining you from Big River First Nation today, Treaty 6. I am privileged and honored to be a part of this panel, and I want to thank you so much for the invite. So I just want to speak a little bit and echo some of Dr. Khan's remarks about how honored I am to be a part of the staff and the Know Your Status initiative. I do have to acknowledge all the dedicated staff over the years, the leadership in this community that is fully immersed in the goals of the program. I am fairly new to the community, and what I see is a community that is open and supportive to the vision and care of its community members who may be affected by chronic diseases, who may be affected by substance use, and then just their openness and supportiveness to the health of the community. It is quite amazing to see. And another thing, remark I need to make is how the community has been pioneers, and not only in this Know Your Status program, but also in community readiness. Back in a time where I can remember, it was about 2013, I was at a neighboring First Nations, and I was giving a harm reduction presentation to the community and the leadership in there. And at this time, they wanted nothing to do with harm reduction. I had leadership walk out of my presentations because of it. So I do need to acknowledge this community and their community readiness, and they've been there for a very long time. So right now, I just feel the program itself has been highly effective by giving people access to care, STBBI testing, harm reduction, case managements with infectious disease physicians, providing care for people who use opioid-based substances. So we have a opioid agonist therapy program here. Engagement with the community, teaching and engaging youth in the schools. So overall, it's been so effective in engaging the community and providing care to community members that is only offered in urban centers. And I think that's a testament to the ingenuity and dedication to the community, leadership, staff, all that's been involved. It's created such an open and honest, caring community. I can't say enough about that. It's also given way to many other First Nations and communities to create their own Know Your Status models in the communities. So right now we are very excited to look at the point of care self-testing kits. We are awaiting obtaining those right now. I think it's going to be a great addition to people finding out their status. We do have to make sure that people's are able to cope and have the supports available when they do these tests. We do have to be able to ensure that there's mental health available to people that are doing these self-tests. And I'm also super excited about testing for syphilis and the dried spot testing. We generally do phlebotomy in here, like Dr. Khan had said. We do phlebotomy testing. We have nurses out in vehicles testing in the back of the vehicles, doing pre-test counseling and testing. And so very excited about those two initiatives that are on the way to the community. I'm looking forward to seeing those.
Great, thank you. So Will's going to introduce the next three panelists, and then we'll ask them particular questions.
Actually, just prior to doing that, just a reminder to everyone that if you have any questions at any point in time, please make sure to put them in the chat box, in the box you have available there. We'll be answering those questions afterwards, but this will become more interactive once we have your questions. So thank you for doing that. Now I'm going to introduce everyone. Okay, Jacqueline Flett. So Jackie Flett is a Two-Spirit Métis woman from Winnipeg, Manitoba, and is a proud mother of 2 boys. Jacqueline is a consultant in Manitoba where she is involved within the HIV movement. Jacqueline has worked and walked with different walks of life and is an advocate and spokesperson for those who live with HIV. Jacqueline is currently an auntie and community host with Kenny Kenechik's Minnow Pamatsuwin Sexual Wellness Lodge. She's also a member of CAN Communities, Alliances, and Networks, and sits on the Collective Impact Network. So I'm going to introduce our other 2 panelists as well, so that everyone actually feels they can contribute at any part of the conversation. Lane Bonnerts is Blackfoot and a proud member of Piikani Nation. Growing up in southern Alberta, Lane's work ethic is one guided by collaboration and uplifting community instilled by a rural upbringing in ranching and agriculture. He is currently the Two-Spirit program lead at the Community-Based Research Center, contributing to sexual health-related programming and research that centers Indigenous identities, cultures, and realities. Lane is currently based in unceded, I'm really bad at pronunciation, and in the unceded territories, in what is currently, actually, let me see. I picked this up, is
Ganyangahaga territory in Jukshaga, Montreal.
Thank you. Thanks, Lynn. Okay. Okay, and Martin Morberg is a Two-Spirit Northern Shoshone and Tlingit man, born and raised in the Yukon Territory. He is a member of the Nacho-Niak Dun First Nation. Much of Martin's work and activism is rooted in community and grassroots initiatives, and he acknowledges that many Indigenous leaders and community members have guided and supported him in growing into the activist he is today. He hopes to pay this knowledge and support forward to Indigenous communities and Two-Spirit people, and contribute to the meaningful work and reclamation of Two-Spirit culture. Martin is a Two-Spirit program coordinator at the Community-Based Research Center. So thank you all.
So my question will be towards Jackie Flett. And I know Jackie personally because we lived together in Winnipeg. And during the COVID-19 pandemic, we had a unique experience in that we kept together as community for 2 years during COVID on Zoom. We met every week for 2 years on Zoom. And I think in other parts of the world that was done as well, to keep people together, to keep a community together, and to keep those supports. So in terms of Jackie's, what does HIV testing and care mean to you?
So HIV testing and care, meaning about know your status is once you become, you finally find that knowledge, what do you do with that information? So how you can contribute to knowing your status and combating STBBIs and getting access and care to treatment. Can you elaborate? I'm sorry.
Yeah, some of the work that you're doing now around doing the Sexual Wellness Lodge and the role of grandmothers or kookums and the role of aunties in that whole testing experience.
So with the testing and treatment here, we have a lot of HIV self-testing care that we've brought into our agency. So we really focus on that cultural component when somebody is tested or reactive. I'm there to walk them through that process and let them know that how it is to live well with HIV. Also, parenting issues for Indigenous women. A lot of cis heterosexual women are getting diagnosed at a rapid rate here in Manitoba. So I think, shifting that focus to everybody gets tested. Every single person should know your status and really take on that initiative and incentive on getting tested.
Well, I know that you have HIV drop-in positive for positive people. That's monthly, right?
Yes, so we have bi-weekly sharing circles. We used to have Sisters of Fire, which was mainly supporting HIV women that were newly transmitted or diagnosed, getting them access to care and support groups. Like Albert was saying, we had monthly sharing circles or weekly sharing circles over the phone during the pandemic because there was a lot of crisis where women weren't able to get that access to care, even just to support while they were going through HIV and HIV care and even transitioning. We had a few people that were newly diagnosed and weren't able to access supports here in Manitoba. So really using that cultural component here at Ganiginichik too, we took the incentive on hiring cookums and mushums so that you can come into our center and talk to a traditional knowledge holder or wisdom carrier, and that you can use medicines with your Western medications and antiretrovirals to really support your care, and so that you're at the forefront of your own care and how you want to be tested and how you want treatment to transpire.
You also bring in like a medical clinical team to do the testing, along with the kukums and the mushrooms and the aunties. What is that relationship like?
So we do have Northern Connections and NACM. So we have Northern Connections that come in. So it's Indigenous doctors. We have Indigenous-led focused programs at the grassroots level, so that we're meeting community members where they're at. We're walking with them alongside them on their journey, whether that come in for STBBI testing or treatment, pregnancy testing, or just HIV testing, and to walk alongside them if they are whatever they may be going through.
Now, I know with some of the tests around HIV or STBBIs, some of those tests require a medical signature, like from a physician. Has that been an issue at your current location?
So the issue was with these HIV self-testing treatments is the language on them. Nobody wants to hear you're HIV positive, so really using the language if there was a reactive, and just allowing those community members, if they do have a reactive, to walk alongside them so that they're not just left in the dust and they don't know where to go, or they might not have a place to access for that future care that they may receive. So we walk alongside them to make sure that they get linked up to a nurse, they get linked up to an AIDS service organization here in Manitoba, and that they're able to receive supports either from myself or anybody else that does community work and engagement with HIV, and supporting those who walk with HIV and live well with HIV.
And what are some of the cultural practices at the Sexual Wellness Lodge?
So here at the Sexual Wellness Lodge, we really look into gathering people for more of a cultural component. So if that's smudging, that's more of accessing cedar baths, asking a traditional knowledgeable or wisdom carrier for guidance using traditional medicines, and really going back and allowing that individual to specialize their care with that cultural component if they feel like they need to.
And your location is it's not in a clinical setting, it is in a neighborhood location.
It's in a neighborhood. We're actually really in the core area of down Main Street. We're really targeting and focusing those who are experiencing houselessness and those who may not feel safe to get treatment at a clinical setting. We also introduced sexual assault nurse practitioners that can go over gender-based violence or anything like that. So we're trying to be a really one-stop shop to have for people to know your status and to access the care that they deserve.
Great, thank you. We'll switch gears here a bit and introduce Lane and Martin to talk about their initiative, the Medicine Bundle, that has gotten a lot of traction over the past few years in Canada, and certainly national recognition at the International AIDS Conference in 2022, where the CBC did an article about the Medicine Bundle, one of the few that actually came out that year in 2022. So I'll start with Lane. Did you want to introduce yourself and talk a little bit about the concept behind the Medicine Bundle and kind of where it's at today?
Yeah, absolutely. Thank you, Albert. My name's Lane Boners. I'm Blackfoot from Piikani Nation, and I grew up in the prairies. I'm from there. I was born and raised in my home territory in Treaty 7, and even though I'm far away from home now, that perspective and experience has always really guided me in the work that I'm doing today. And I think back to when I was younger, a lot of my understandings around HIV and sexual health were influenced by religion or misinformation or no information coming from that small community. Moving to the big city, I wasn't prepared for that environment. And a lot of my early relationships revolved around fear and anxiety. And I really needed to seek out information to try and make myself feel better in these spaces. And I think with a lot of these initiatives like Know Your Status and the Medicine Bundle, we're arriving at this place where information is actually starting to find the people, and people don't need to search for it in the same way that they had to before. I am not living with HIV. I've been on PrEP, accessing it through non-insured health benefits since it was added to the formulary in 2016. And the biggest impact that being on PrEP has had for me was on my mental health, in being able to take action over my own body and having that sense of choice and control. That improved my relationships, and I was able to enjoy my life a lot better in knowing that there was something active that I was able to do for my physical health. I believe that the Medicine Bundle really tries to accomplish the same thing with regard to HIV self-testing. And what that idea was how we could ensure that when we're going through this process of something that can reveal something we may not know about our physical health, that all of these other aspects of our health are also accounted for. So the Medicine Bundle contained HIV self-testing kits and traditional medicines originally selected by the person accessing the bundle to reflect their own beliefs and teachings. We've grown a lot in a very short amount of time, and most of our bundles contain medicines like sage, cedar, sweetgrass, to ensure that that spiritual piece is also being nurtured through this process that could be really stressful and uncertain for someone's mental health, and making sure that those resources are also included for people to know what can happen next and reaching them directly. I use HIV self-testing in my own life as well to know my status and to do so regularly. In between my PrEP appointments for HIV self-testing, I do it just as a little bit of peace of mind and really keeping that mental health piece front and forward. When I think too about bringing these resources to a prairie context and really knowing what it means to work in a small town, I just think of my own hometown and how you really need to from that space or have an ally in that environment that can really speak to what's going on in that community. Because I think of home and how during times of grief or crisis, for example, everything stops and community turns in and they take care of each other. Or this reality that in smaller communities, you're also surrendering to the environment in a lot of ways, in the sense that if we're having bad weather, the whole infrastructure of the town shuts down. The school buses stop running, the clinics are closing, childcare isn't available. And that's a limit on how we can provide resources in that moment. Coming from an area that's heavily influenced by agriculture and ranching, you have to respond to the weather in that moment. So there are times where people just simply do not have the space to have these conversations around sexual health because there are other priorities that happen first in those small towns. And really having someone that has a sense of when and who these things are happening to allows for a more consistent and intentional approach to these initiatives in the community where people are actually able to have these conversations. The medicine bundle was really special in the sense that it was accessible to anyone across Turtle Island. They were able to fill out a form online requesting HIV self-testing kits and the medicines, and we were able to ship these resources directly to their door. And that was kind of our first and initial response to getting these tests out to community where they need it the most.
Great, thank you. And Martin, you're with the Two Spirit program at the Community-Based Research Center out of Vancouver, BC. From my reflection during the COVID-19 pandemic and the intersection with the HIV pandemic, I saw a lot of young women who were recommending on Facebook to use our traditional plants to smudge, use tonics and teas with regard to preventing COVID transmission. And then it sort of segued into art and creativity, where a lot of people began beading during the pandemic because they were at home. And then we're making ribbon skirts as well. And that continues to this day. It is really a phenomenon of using art as a mechanism of promoting wellness and health. So your medicine bundle involves some of that sewing, traditional, cloth in the bundle as well as medicines. Do you want to sort of describe that, how it came about to be a physical sort of entity with cloth and sewing, and then the introduction of the medical information, but the testing kits, but also the medicines? What was that process like?
Well, thank you so much for the question. And I think one thing that was really important was just about like the visibility of indigeneity. I think often in Western healthcare settings, they could be very foreign, very alienating places for Indigenous people. It's very seldom that we walk into a clinic and see, anything that we can relate with or that we can identify with, that's like culturally significant. I know that personally for myself as well, it's been my experience that, spiritual health has largely been overlooked in Western healthcare settings and like settler approaches to care. And so, there was a lot of these gaps, that I was discussing with other people, other Indigenous people that were living with HIV. And so when I was diagnosed with HIV 12 years ago, there was very little available to me. I was kind of like smothered with a lot of these pamphlets that had jargon and information and things that I just didn't really understand, coming from people that I couldn't relate to. A lot of fear mongering, a lot of pressure around like disclosure and like medication adherence. And, so it took me, a couple of years before I was ready to make a decision in seeking like HIV care. And so in that, like, and kind of what I understand and what I gather from my engagement with the community is that we understand that, these tools are effective. Like things like HIV medication, they're effective. People can live, with an undetectable viral load, and we're living long and healthy lives when we adhere to our medication. And, these HIV self-test kits work. And so there is this understanding that, okay, we understand the effectiveness of these tools, but it's in the approach or in the knowledge translation coming from hierarchies of settlers that is, trying to translate this into Indigenous communities often is where it's missed, or it doesn't land, or it's not impactful, or, it creates harm. And so, like this whole medicine bundle and the creation of it was with the understanding of like that spiritual health component that was missing. And so we saw all of these self-test kits becoming available in Canada. There was very limited that were being promoted to Indigenous people. And so, there was a couple of Two-Spirit people at CBRC that started to do consultations and interviews throughout the province of BC with Two-Spirit and Indigenous people and healthcare providers. And really, they were just exploring the feasibility of an HIV self-test kit in rural and remote communities. And so, from those consultations, I understood, and I think our program understood the need for community involvement, that if we were going to create these pathways to an HIV self-test kit, that we really needed the community to lead the way. And so there was a lot of effort, there was a lot of time, there was a lot of money and resources actually put into community consultation. We established a committee. They were making decisions, they were really leading the way in, the sexual health medicine bundle. And so with that, we were able to really create something together collectively as like an approach to Indigenous care, so that when somebody engaged with a medicine bundle, they had an opportunity to engage with some spiritual health. They had something that was visibly Indigenous. They had something that like had a more holistic approach instead of looking at things as such a physicality. And so, like, I just want to end a little bit with my own status as well, in the sense that like, I understood that the medication was going to keep me alive. So like understanding that the effectiveness of it, but where I really needed the love and the nourishment and the support was my own spirit. And so I received that from other Indigenous people. It was Indigenous women that pulled me into the HIV movement, that loved me and nurtured me and role modeled for me and demonstrated and mentored me and really taught me how to journey with HIV. And so it was through that nourishment that I felt strong enough and prepared enough to then adhere to the medication. So it was very much like a vital component in my overall health. And so we see that in like approaches to testing and approaches to, seeking care and support around our sexual health, anything to do with our physicality, is that in order to improve overall health outcomes, we need to be mindful of like the culturally appropriate tools that we use as Indigenous people as well. And, there has never been an ownership to the medicine bundle. We have never claimed ownership over it. We have been very generous, very transparent. We have done hours upon hours of consultation, engaging with communities in meaningful ways, trying to make it accessible to people. And, we're looking at a national expansion. We're looking at really, addressing a lot of the barriers that Indigenous people are seeking in accessing that kind of testing.
Thank you, Martin. One of our kukrums at the Sexual Wellness Lodge is behind Jackie. That's Gail Pruden, longtime activist for transgender Indigenous people in Canada, but also around HIV and STBBIs and works as one of the program. You want to say hi, Gail? I know you just came from the PAW. Say hi.
Can you hear me?
Yeah.
Hi. I'm heading out to the powwow tomorrow. I'm going to be trying my jingle dress.
Okay, we'll see you there.
And I went to Show Lake 40 already. I danced in my tea dress, so I'm getting there.
Okay, miigwech.
All right. Nice seeing everybody. Hello. I missed you all.
So, going back to Jackie, you had the opportunity to attend the International AIDS Conference, the 24th one in Montreal a couple of years ago. What was that experience like for you?
It was actually my very first conference, like a really big conference like that. It was really good to network and be around so many other positive people that actually knew their status and that were doing something about it effectively and dynamically. It was really great to be around positive people from all over the world and allowing to hear their initiatives and their incentives on how they combat STBBI I guess like stigma and how they get access to care and treatment in the places they're at.
Great, thank you. The Pope came from the Vatican in 2022 to apologize for the harms of the Roman Catholic Church in running Indian residential schools and day schools for over 100 years. And that really affected for many Indigenous peoples, the ideas about sexuality, relationships, the idea of sinning and shame. So in terms of, U equals U, which is undetectable equals untransmissible in terms of HIV positive people being sexual. What are your ideas about that in campaigns like around the self-test or support services at the community or at the urban level with the U equals U campaigns? Is there work that we need to do on that? So I'll just put it out there. Lane?
With U equals U specifically, I think back to conversations that I have with my family back home, and they know that I'm engaged in this work. I've been working in HIV and sexual health for a really long time. And I was trying to describe that concept to my relatives back home, and they heard the word undetectable, and immediately there was this reaction that I hadn't heard before. And they were like, what you're saying is a really good thing. It's a really beautiful thing that you're teaching us and what that means with medication adherence, not being able to pass on the virus. But that word undetectable actually scares us, because when you think of such a community and how everybody kind of knows everybody, a little bit nosy sometimes, getting in everyone's business there too. Undetectable feels like there's something that you're trying to hide, or that there's something that you're trying to pass under the radar. There's this sneaky quality to that has been associated in that space. So how can we communicate it in even more real language that people are familiar with, and they can just say, oh, okay, this isn't something that we need to be fearful of. This is something that needs to be welcomed and embraced by our community. And growing up in rural spaces, there's that discomfort with sexuality and conversations around it that's been introduced heavily by religion. But there also are environments and circumstances where people are very willing to talk about sex, especially environments where agriculture is very persistent. They're going to be telling you what they're doing in the fields all day with their crop and cattle, but come into the house and all of a sudden anything to do with me or someone else, that becomes a little testy, taboo, or juicy. And really kind of recognizing and paying attention to where people's comfort level is and in what context they're comfortable in understanding or talking about sexuality, I think is going to be really essential in how we continue to bring initiatives like the Medicine Bundle and Know Your Status into these smaller communities to address these needs.
Yeah, because I think some of the assumptions people would have, well, if you're diagnosed with HIV, that you should not be sexual anymore, right? Just those sort of initial reactions of the public. So, Martin, do you have any perspectives on U equals U and reaching Indigenous leadership like First Nations, Inuit, and Métis leaders who are sort of guiding the health development across Canada and these conversations about U equals U, or has it even reached that level of awareness with our leadership?
I think I just know from my own experience and like the work that I've done across, the country and the Indigenous communities that I've kind of worked in or been a part of and what I've realized is that there is a lot of privilege had in urban city centers. And there's a lot of jargon and kind of code that we understand in the sector, in navigating sexual health experiences, using things like, U equals U, or I'm undetectable, or I'm on PrEP, and just the amount of access that we have. And so, like knowledge translation and knowledge mobilization, I think within Indigenous communities really needs to come from the messaging needs to be the Indigenous faces that are actually translating that messaging in ways and in contexts that people understand. So like, even for myself, like I've never been to like rural or northern communities in Manitoba. And so I don't have an understanding of how their dynamics work and how they mobilize knowledge amongst themselves. And so I think that really it's about like local engagement and really exploring of like, how do Indigenous people talk to each other? How do they mobilize knowledge amongst each other? And so there are initiatives that are going to be coming up in the future that the Two Spirit program is working on, engaging with communities in like culturally safe ways. And like what I find too is that like there are so many warriors that I know across the country, like just generous, powerful, articulate, knowledgeable warriors in their communities that are so generous and willing and want to contribute to this movement, but aren't given the microphone, aren't given the spotlight, aren't given the resources or the funds to be able to mobilize the knowledge that they have. And it's often those Indigenous people with those intersections that have a further and more effective reach in their own regions than settler executive directors at the top of these hierarchies will ever have. And so when we translate knowledge into communities that we've never been a part of, I really see it as like a very modern version of assimilation. And so it's telling them what we think that they should know in jargon and vocabulary and terminology that works for us, assuming that it'll work for them. And so really, I think it's about that local engagement. It's about those leaders. It's about those, warriors, about the elders, and about the community and how they mobilize knowledge amongst themselves and really engaging with them in meaningful ways. And doing it with like sustainable resources and funds to be able to mobilize that kind of knowledge. So I guess what I'm saying is like, what I've learned is I can't make the assumption that because I can go down Davie Street and say I'm undetectable and it lands does not mean that I can go into a northern part of the Yukon and use that jargon and expect it to land the same way and have those same results. So I think it's really about like local language, local dynamics, and those warriors and how important and vital they really are in the movement of, knowledge translation of HIV prevention.
Thanks. So we do have a question. William, do you want to read it?
Sure, I'd be happy to. So this is a question from Doris Peltier. In listening to all the speakers, it is obvious that community resourcing and involving communities is so needed. Community-led responses are an integral piece in reaching those who most need support. It is also an opportunity for communities to be part of the response. 3 tremendously good models have been discussed here. This gives me hope that communities are responding, albeit the response came at a time when this was becoming a health emergency, as in Big River. Lots of resourcing went into the community to respond, and it is good to hear about their initiatives, as Darren talked about. My question is about the need for more resourcing of communities responding to HIV and STBBI, i.e. syphilis. Should this be considered moving forward, rather than always responding in emergency mode? Why do we have to wait until HIV and STBBI has become an emergency? So really, the question is around the temporality. Do we need to wait for things to be an emergency before we respond? And
Well,
that's a question open to the panel.
Yeah, that could be for everybody, but I think from my perspective, the Public Health Agency of Canada released its renewed STBBI action plan this week. So we can look at that and just get a sense of what is specific to deal with the urgency of Indigenous peoples and HIV and STBBIs in Canada. But I think from my perspective, is colonialism is a machine. It doesn't have eyes or a brain, and it just does what it does. And HIV and syphilis outbreaks are the outcome of that machine, right? Is that underfunded anti-Indigenous racism, lack of housing in communities will naturally result in high incidence of HIV. So to me is that the colonial structure has to be addressed if we're going to truly address these outbreaks in Manitoba and Saskatchewan, and likely Alberta as well. So there's symptoms of that colonialism, and just sort of that Indigenous people bear the brunt of colonialism. So I'll open it up to the other panelists. Why does it have to become an emergency before HIV or STBBIs gets attention? Anybody?
I can say a few words, Albert.
Go ahead.
Thank you so much, Albert, and you said it very beautifully, the impact of colonial structures and practices and way of thinking. I think in Saskatchewan, the entire response to the STBBI and currently the STIs, and this particularly the syphilis crisis, is very, very much in the thoughts and minds of our partners. From ISK standpoint, we from the very beginning, since even before the Know Your Status program came into this current state, there is quite a partnership and coalition among Indigenous leaders in Saskatchewan, and we work with them very closely, and the entire feedback, the entire input, how this response should be in Indigenous communities in Saskatchewan is coming from our leaders and from FSIN to the tribal council, tribal chief, health directors. So we have in different times that structures of that input collection has changed, but I think the basic elements of the partnership and the input. And I'm so happy that you were at the last year 2-day CAN session that actually discussed all the barriers and issues that our Indigenous people are facing when it comes to STBBIs across the country, and particularly in Saskatchewan. Our partners spoke very loudly, and PHAC heard that, ISK heard that, Health Canada, many partners heard that how this entire STBBI crisis, where is it coming from, how is it being dealt with, how it's responded, and what can we do to respond more effectively. And I totally agree that why would we let it become a crisis like that while we can respond in any given time to some of these things. So in terms of resources point of view, Saskatchewan, we work with Dr. Wong and our partners in other organizations to get as much as resources for our communities. And so far, we've been very lucky that Saskatchewan, in terms of the HIV, STBBI, elevated rates and the crisis, we have been directing those resources directly to the communities, and communities basically decide. So we have a STBBI technical working group that is led and run by our Indigenous partners in Saskatchewan, from tribal councils and Big River First Nations is there, Ataka Cree Nations, many of our community partners are there. And from the day-to-day responses to crisis, to routine, all those input, insights, wisdom come from our communities, and that's how it's translated and put into action when it comes to the community level response. And I can tell you, you have seen the way you have seen the response in Big River. The neighboring communities, the Ataka Cree Nation, they have exactly similar level of response. And in many communities in that area, in the central areas, from Onion Lake Cree Nations to File Hills Propel Tribal Council, Saskatchewan Tribal Councils, many communities have, and tribal council have launched their programs. They have their own nursing, they have their own connectivity with Wellness Wheel, Dr. Skinner's, and the evolution of the Know Your Status type of program is so remarkable in each community and in each tribal council that you can hear stories after stories from our partners when it comes to the response in Saskatchewan. And I'm very proud to be working with you and with Margaret and many other Indigenous leaders to lead that response, that the leadership, the entire operations of the program is coming directly from the communities and the input from the on-the-ground people. So I'm really happy that we are moving in that direction. And the entire concept of the impact of colonization and the colonial thinking is I see a reverse of that in our day-to-day programming and services. So we keep that momentum, and more community have the chances and the opportunities to provide that input from the community level, the way Big River has done that. And they lead the program, and they understand, they know the best what works for each of their band member.
So I'll ask Darren as well to respond. Why do we have to be reactive around HIV after 40 years of knowing about the transmission of HIV, being in the 21st century, that the prairies are becoming a hot spot for HIV transmission, even though we have the technology, the knowledge, the treatment. And, why do we have to wait till it's a crisis? So Darren?
Great, thank you. Yeah, I really agree with Doris. I don't know why we have to wait till it's an emergency. It is waiting till it's an emergency is such a downstream approach, where we all need to be in that upstream approach, looking at securing sustainable resources and providing all sorts of plans and organizations into testing and engagement with communities and building capacities. And I think oftentimes, and this is just from my own experience working in rural First Nations in Saskatchewan, is that we are given a lot of workload with limited funding, and then we all have mandatory programs that we have to run, and then it's often tough to increase workloads on nurses that have a lot to do, and really not having anybody else come in and provide additional supports. So I can all I can say is I totally agree that we should not be waiting till it's an emergency, and we need to move forward and work on that upstream approach. Thank you.
I think the same for Lane and Martin. how could your medicine bundle be applied in this situation where it is now becoming critical or an emergency situation in the prairies?
Yeah, I just want to speak to Doris's question really quickly, because from a community perspective, and this is speaking really, really broadly, a lot of people don't seek out information until it impacts them directly. And something that continues to persist with regards to HIV is that conversation largely excludes folks in rural areas. You know, we still have these misconceptions that it largely impacts the gay community and the gay community alone, and it's leaving a lot of people that are being drastically impacted out of the conversation now. Even with regards to the medical system as a whole, we're still always responding to symptoms instead of working to actually try and prevent those symptoms from ever occurring. And that's just the nature of the healthcare system. What I see and what I really want to commend is, you know, the Minnepamatsu and Sexual Wellness Lodge working within the broader scope of Gani-Kanichik, and how many other needs and resources can be tended to at once in those spaces. That someone might be coming in for something completely different, and that opportunity to have this conversation around sexual health can also occur. And I do think that there needs to be more of an emphasis on service providers more broadly. I'm not speaking just to clinicians or doctors or nurses, but recognizing that when we're talking and looking at testing or prevention, as service providers, there may be a responsibility there to initiate a conversation that has never happened before. Because until people actually experience it and are in these crisis situations, they may have never thought to question or ask about it to begin with. So I think that there needs to be a more proactive approach in how we can actually initiate conversations with community in more varied circumstances.
Martin, so again, how would you apply the medicine bundle concept to an emergency situation with HIV in Canada?
I too just want to address a little bit of Doris's question first.
Sure,
And
yeah.
I think it's really about like funding distribution and like the eligibility criteria that's put on that. Often you need like all sorts of like published articles, you know, grad, masters, PhDs, you know, these like settler researchers, principal investigators. There's all sorts of requirements and boxes to fit in and hoops to jump through in order to prove that you're going to do this work for the community. And like, so I think it was kind of touched on earlier, and I've seen a lot of this is these Indigenous organizations or these First Nations, or you know, these warriors that are just completely overwhelmed, you know, with the amount of work that needs to be done in their communities, and have limited capacity to be pursuing these like larger funding bodies that would essentially give them like the sustainable resources that they would need to mobilize things like, example, the medicine bundle in their regions. So often are completely overlooked, as you know, these funding bodies are deeming, you know, what is valid knowledge, what is valid eligibility, what is, you know, valid criteria of what, you know, these groups need to be producing in order to be deemed essential or in need enough to then grant them the funding to do the work that they need to do in their communities. And so when you see things like Know Your Status getting mobilized in a province like Saskatchewan in collaboration and partnership with First Nations people and nations, is like, there's the approach, you know? And I think things like the medicine bundle is very kind of like dynamic in the sense that like it differs depending on the distinct group engaging with it and the needs within those communities. So I think the way that we viewed it is like, here is a tool that will offer spiritual nourishment as well as access to like effective tools and in like taking care of your sexual health needs. But, you know, in different regions, in different reservations, the medicines could look different, the resources could look different. You know, we've discussed like harm reduction bundles, we've discussed, you know, like women's bundles. And so really it is kind of this toolkit that could be used and adapted in, you know, various ways to best serve the region, you know, that it's being delivered to. And we understand how important it is to really engage and provide resources to those local leaders, to those local warriors that want to do this work and have a much deeper, more accurate understanding of the landscape of their region. And then they take the lead on saying, this is what we need in a bundle. This is what we need. You know, these are some ambassadors or messengers or leaders or elders that we need to engage with in this process. This is some of the care and support that we can provide. And these are the tools that we need for this specific region. And then it's our job to support them in their lead, in their self-determination, in their autonomy, and to provide those resources, that knowledge, that capacity, and that care and support so that they can do the work, those warriors can do the work in their communities. And we're just kind of there to be that supportive role and providing what they need, you know, to implement something like the medicine bundle, which would be culturally specific to the needs of their own communities.
Thank you. And Jackie, we know in Manitoba we had 260 diagnoses for HIV, and certainly a post-COVID impact. And that was in 2022. In 2023, we have 350 new cases of HIV for Manitoba. And so it is certainly for individuals and communities becoming a crisis of diagnosis, but also for the service level, whether it's testing or treatment or engagement. How do you feel about you know, your work at the Wellness Lodge and these new populations of newly diagnosed and dealing with it from that perspective in larger numbers of people coming forward for care?
I think it has to do with a lot of rate. It's straight under education. So, and there's not enough funding. So there's not enough nurses that go out into northern communities that can reach the populations that really need to be seen. And to get access into those northern communities, you need to really have community engagement and building capacity with the members of that community. So that's getting in with their elders and their youth, which are extremely hard in Manitoba, some especially in fly-in reserves. Here at Ganneganeshik, we're able to see all different walks of life and able to cab them in and cab them out to wherever they are. We have also a traveling lodge. So what we're able to do is making community partnerships and going to these different agencies. So we go out to them instead of them coming to us. We actually go seek out individuals to get them the access to care that they need and require.
Thank you. So we're sort of coming to the end of our session today. I want to thank you all for participating. And do you want to talk about how we can contact you? I know Darren with Big River website. Oh.
Yes. So you know what? I don't even know if I'm on the Big River website yet, but I can get my contact information to somebody on this panel that might be able to send it out. I can put it in the chat box or whatever works.
Great, thank you. And Lane and Martin, how can we learn more about the Two-Spirit Medicine Bundle?
I think our website is currently under construction. I think Lane could probably answer this a bit better, but we're listed under cbrc.net.
Yeah.
And then if anybody would want to contact us, it's just our name dot our last name at cbrc.net. So I can post it in the chat, but it would only be made available to the hosts.
Yeah. We'll add a link to each after this when we put it on, because this conversation will be on the Fee Center YouTube channel. That we could add those linkages as well as Jackie with the Go Ask Auntie and the Minnepamatsuan Wellness Lodge.
I think Lane maybe wanted to add something to that.
Sure, yeah, Lane.
No, I think Martin pretty much said it all, but yeah, the best way to get in touch with us about the medicine bundle and any of the other initiatives happening at CBRC right now, the Two Spirit program, is to contact one of us directly.
Great, thank you. So any last words from Will or any of the panelists before we close off?
So I would like to just really thank all of you as so Albert, Jackie, Martin, Lane, Darren, Ibrahim, thank you so much for agreeing to participate in this panel. I think it's been a really fruitful and really important conversation to share more broadly. We have like our audience has been about 30 people most of this time, but given that this will be recorded, please share it more broadly. We want to get this out because this is important. So thank you all. Thank you as well to the audience for attending. We really value your participation. We value you being here. This is like part of an ongoing series, and we're always up for suggestions for like upcoming conversations. So if you have any, please feel free to reach out. All of our contact information will be shared with this with the recording. That's it.
Thank you so much. Thank you, Albert. Thank you.
See you all again.
Thank you, everybody.
Bye.
Everyone.
Have a nice
Peace.
weekend. Have a nice weekend.
Bye.
Good weekend, everyone.